Okay, good afternoon, ladies and gentlemen. Can you all hear me and see me? So I'm Mike Risebury. I work at Basingstoke, and many of you might know we do a lot of knee osteotomy surgery in Basingstoke, and I want to share with you today just some general principles, thoughts around planning osteotomy, techniques of the surgery, and the use of allograft, the use of different plating systems, and also the potential advances in osteotomy surgery in terms of future developments. I'd just like to acknowledge my colleagues at Basingstoke, too many to list here, but these are the key guys working with me on the osteotomy project. Just to remind you that don't realise that osteotomy is the key. If you look at any algorithm in terms of knee pathology, number one is alignment, and these are in order of importance. So the alignment is absolutely critical, both coronal and sagittal alignment of the knee. Secondly, ligament stability is important, then the meniscal pathology, and lastly, the joint surface is important. So there was a big focus on the 80s and 90s on meniscus and joint surface and partly ligaments, but the alignment was largely forgotten, and I'd just like you to remember that that's the key. This slide is courtesy of Roman Sile, who's the current president of ESCA. He's a long-term friend and colleague of ours at Basingstoke, and he produced this slide, which is really highlights the issue and the problems surrounding knee arthroplasty. So what we want to do is stay in the green zone, ideally, so with your own knee, and that might be cartilage or meniscus repair surgery, it might be ACL repair or reconstruction, joint surface repair, it's braces, it's pharmacology, but I would include osteotomy in that group. So it's basically a knee preserving procedure. Once you're into the amber zone of uni and total knee replacements, that's a commitment to arthroplasty, and particularly in the young and middle-aged group, that's a problem for me, because when or if it goes wrong, then you're into the salvage zone, which is the red zone, revision knee replacements, arthrodeses, potentially even amputations. And we all know these are often very unhappy patients, particularly if they're young. So in that young and middle-aged group, I would try and think away from arthroplasty, and if we can do knee preserving procedures, and osteotomy falls into that category of surgery. There's a paper here that I presented in my Oxford talk. We were talking about unicompartmental versus osteotomy, a largely historical argument, I'd say, because the overlap is actually quite small. And I would say that most patients I'm considering osteotomy surgery on, I'm not considering uni on. There is a bit of an overlap. This is Giffin's group, and he's a big protagonist of osteotomy surgery. He works out of Fowler Kennedy in London, Ontario. And this is a paper that basically talks about the massive emphasis of the role of malalignment on knee load, independent of the patient's body mass. So it's to do with malalignment loading different compartments of the knee. In very broad terms, indications for a medial opening wedge HTO, or a lateral closing for that matter, if you prefer, is someone with medial knee pain with varus mechanical alignment, possibly early medial OA or pre-OA, i.e. meniscal loss, chondral damage in a young patient. It's probably important that they have Kellgren and Lawrence grade 2 or less affecting the lateral compartment. I think the patellofemoral joint is largely unimportant. And actually osteotomy can be used to treat lateral or medial facet patellar disease depending on alignment. Ideally we want young patients, but young is a variable feast, and obviously in modern times people can be young in their 60s. If they're physiologically fit and active, you might want to consider knee preserving procedures. I've said there varus alignment is important. Obviously you need to be in some varus to consider a realignment. If they're neutral or valgus, then it's not a possibility. And I've said there ideally metaphyseal varus. What this refers to is a historical paper by Bonin and the French group in, I think, 2004. And it's looked at a lot by the Oxford group also, which talk about patients with congenital metaphyseal varus being the ideal group for osteotomy surgery, because you're actually correcting a deformity in their tibia. And if you look at this case I have up on the right, a guy who had bilateral simultaneous osteotomy, is a very fit 60-year-old guy. You can see that he has congenital tibia vera, and actually that's his main problem, with some slight narrowing in the joint. So maybe these are the ideal patients. And the final point there is talking about post-correction and MPTA. I'll go on to that, the medial proximal tibial angle of less than 95. Obviously, the normal range is 85 to 90, i.e. slight varus through to neutral. We wouldn't accept a oblique joint line of more than 4 or 5 degrees after the surgery, and we'll come back to that. It's really important. This is a paper presented by our group. John Palmer was the first author, and was our group at Basingstoke. We looked at unis and osteotomies very broadly and looked at their results. And in basic terms, the functional outcome at 2 years was very comparable, and that was independent of BMI. It was independent of gender. And it was obviously very encouraging data. Talking about contraindications, there aren't many. It's like many things. If someone's got symptomatic bi or tricompartmental arthrosis, obviously an osteotomy is probably not something you're considering, although in rare cases you might. We'll come back to that. If someone's got an inflammatory arthropathy or vascular disease, then that's something that would contraindicate it. There are lots of relative contraindications, and I think the textbook osteotomy patients from 15, 20 years ago, we've largely discounted a lot of those relative contraindications. Now we've got the results and the data. But I would talk about a significant sagittal plane deformity being a relative contraindication, so a big FFD of more than 10 or hyperextension of more than 10. But I'd counter that comment by saying you may be able to treat that problem with an osteotomy when you're talking about the more complex slope changing osteotomies and so on. So I'll come back to that. Severe tibial subluxation, so tricompartmental disease, as I said, an inflammatory arthropathy, osteoporosis, a heavy smoker, and again that's controversial, but it is a big issue in terms of bone healing. And the last one's very important. The patient needs to understand what the surgery is and needs to understand the importance of the rehab and the length of the rehab. In terms of the technique, we've talked there about the x-rays. It's quite important not to jump these steps. The planning is the key. So good x-rays, AP, lateral, Rosenberg. I would also say a skyline, that would be standard in our unit, but also well audited long leg x-rays are vitally important. And then we would normally do digital planning, which is Miniachi's technique. And I've said there we'd aim for a Mikulicz point on average of 52 to 55%. What I mean by that, the Mikulicz point is essentially the weight bearing axis from the mid hip to the mid ankle in stance phase, in static stance, and 50% being the middle. So 0% is the medial edge of the tibial plateau, 100% is the lateral edge. And it's easier to talk about percentages than angles. Talking about the old fashioned, if you like, Fujisawa point or zone as it should be, it's 62 to 67%, and it's really quite valgus. It's the downslope of the spine in most patients. We're now being a bit more cautious, and in most patients are looking to go just past that midpoint in most patients. I've said there, consider a DFO or a distal biplanar if the wedge is greater than 14. And again, that relates to joint line obliquity, but also potentially patella baja, and we'll go back into that in more detail. I reference this paper because this comes from my Oxford talk, and it's an Oxford paper written by Prof. Price and the chaps. And what they're talking about is backing up what I'm saying there, which is 55%, i.e. just past the centre, just into valgus, is probably the ideal correction in terms of balancing the lateral stresses with the medial stresses and not overloading the lateral compartment. In my experience, someone who's inadvertently corrected into valgus is one of the biggest problems, and we're trying to be more neutral in our correction, but it all comes down to accuracy of planning rather than accuracy of technique. In terms of our technique, generally we'll do a small mini incision, which is essentially oblique, almost transverse, with a stab incision distally. This very much depends on your experience and depends on what device you're using. I would say if you're an inexperienced surgeon, a longitudinal incision so you can see everything is safer. I've put it in bold there, but the medial collateral ligament release is absolutely vital. And for those of you who haven't looked at it, I'd urge you to read Agnes Kirshner's paper from 2007, which is Philip Lobenhofer's group, and also the use of a biplane. The biplane we'll come back to, and I'll show you what that means, but essentially it's critical and vitally important in distal femoral osteotomy, possibly less so in an HTO, but I tend to use it routinely unless I'm trying to change the slope. Use of bone wedges, whether they're synthetic or real, is controversial and probably not required for union, but again I'm going to come back to that in more detail. And some form of rigid plate fixation seems to be the best in terms of maintaining your hopefully accurate correction. In terms of the post-op rehab, it partly depends on the patient. It partly depends on the device I've used to fix them and the patient's size, etc. But I would say that cryotherapy is absolutely critical, and I use the Game Ready device wherever possible for osteotomy surgery. It tends to be a painful operation, particularly opening wedge osteotomies. And I think if you can control that bruising and swelling in the early days and weeks, the patients are very grateful. And I have to say it's revolutionised my practice, not only for osteotomy surgery, but I use it routinely for unis and total knees as well. The patients can full weight bear, but in reality, for 2-3 weeks, I tell them to really take it easy, partially weight bear, rest, ice, elevate, and just gently get the knee moving. I don't see the advantage of pushing it in the early 3 or 4 weeks. It's a longish recovery. At 6 weeks, they get plain x-rays to check nothing's moved, and I tend to do my long leg repeats at 3 months because more patients are more comfortable standing correctly at that stage. In terms of our outcomes at Basingstoke, these are ever changing. We've also got the Tri-Series linked with Cardiff and at Carlisle with Matt and Chris. These are our patients, 562 patients. These are HTOs only. Interestingly, more women than men, which is not typical. It's very typical to have much more percentage in the way of men, but our data suggests there's no difference, and therefore we do more women than other units. We've got nearly 500 patients with complete scores. The average age, as you'd expect, is 46. I appreciate that range is huge, 17 to 79, and that might sound crazy, but obviously at Basingstoke we do treat a number of tertiary referral patients, probably a third to a half of our patients. So those younger patients often have growth plate deformities, and there are a handful, and it is literally a handful of older patients who are very fit for their age, and often they self-select to not wanting knee replacements, having seen friends had bad results. But I don't want to suggest we're doing lots of young and old patients. Most patients are middle-aged, if you'd like to use that term. In terms of complications, overall 13%, that sounds a lot, but most of them are manageable complications such as superficial infections, a few wound washouts. We have had some delayed unions, but only 14 out of over 500. Removal of metal isn't a complication, obviously. That's a choice put to the patient. Just over half of our patients so far have had the plates removed, and I suspect that will increase. The vast majority of our patients have been done with Tomafix plates, probably around 80%, and it is quite a bulky device, and patients often want it out because it feels tender around the medial side of the knee. We tend to ask them at a year if they want the plate out or not. I certainly wouldn't want to remove plates before a year in the vast majority. At time of writing, we have revised 5 HTOs. That was for malcorrection, often overcorrection into valgus rather than undercorrection. Interestingly, if patients are undercorrected, they're often quite happy. We just don't know the longevity of the effect, and that's part of why we now would advocate aiming for neutral corrections rather than valgus. And 4% had been converted to arthroplasty, which isn't bad given that this is a 10-year series, although the numbers are smaller in that group, as you see. And if you look down the table, just very briefly, in basic terms, there's no point in measuring them before 6 months because it's quite a painful procedure. Post-op, at 3-4 months, it can be tricky. It takes patients 5 or 6 months to get to that turning point. But if you measure all the scores, they increase significantly, almost to the level of unis at 6 months. And you can see it increases over the first couple of years. And interestingly, at 5 years, the scores tend to be higher. So that suggests patients get more and more comfortable, and we don't see a deterioration in effect. In terms of advances, this is obviously a complex area that I'm just touching on today, but there's a lot of talk of PSI or patient-specific instrumentation. I think this is probably the future for osteotomy surgery, as I believe it probably is for unicompartmental surgery also, either that or robotics, because the accuracy is clearly the key here. Not only the accuracy of planning, but then translating that into the operating theatre and being accurate in your surgery. And there are several papers that show robotics or navigation are much more accurate. Interestingly, as with many things in orthopaedics, that doesn't seem to translate into patient outcomes, which is disappointing, but I suspect is understandable. The final thing I'd say about advances is in terms of fixation. So for over a decade now, the Tomafix, for example, has been the gold standard, and it's a very heavy, large, over-engineered plate, which is largely why it's quite successful. But it is irritating to the soft tissues, it is bulky, and in some patients, they really dislike it. So I think lower profile plates, smaller plates, potentially even bespoke plates or nails, which is interesting, may cause less soft tissue irritation, and that's part of the future. In fact, it's already there, but we're developing this. As I've said already, planning is the absolute key. So pre-op planning is the critical step here. Forget osteotomy surgery unless you can set up your planning properly. And it's a multidisciplinary thing, which we've really fought hard for at Basingstoke. The key to this really is the good quality long leg alignment x-rays in basic terms, with your patelli pointing forward, so there's no rotational problem with your x-rays, and we should quality control those. The other thing is the clinical examination. So it's obviously critical to your planning that you know what the soft tissues are doing. So particularly AP and medial lateral laxity, rotational laxity. It's important to give your planners, if it's someone other than you, all that information. And I would talk about, particularly for HTOs, which is the workhorse of our surgery, if you like, that triple varus with the varus thrust and the increased lateral laxity and posterolateral laxity is absolutely important. And I think you need to know that information when you're planning. And we can go to that in more detail in the question and answer. But essentially, if you've got massively increased lateral opening on the injured or varus side, you need to reduce to a certain extent your bony correction. Otherwise, you can go past the tipping point and overcorrect, i.e., some of their deformity is in those lateral soft tissue laxities rather than the bone and the arthritis. For complex cases and potentially routine cases for PSI, you might want to use CT and rotational alignment, but basically we're using the Miniachi method, which is the computer equivalent of drawing lines on long leg x-rays. The accuracy of the surgical execution is critical. I've talked about the biplanar cut many times. I use it routinely unless I'm trying to change the slope, and you can see it demonstrated here on a sawbone I did on the Osteotomy Masterclass in Newcastle. Two things to point out here. One is the trapezoidal gap, and what I mean by that is the wider base posteriorly and the narrower base anteriorly. Because of the triangular nature of the tibia, this is an anteromedial operation, not a medial operation. So if you want to maintain the slope while introducing some valgus, the measurement has to be taken at the posteromedial angle of the tibia. And if your gap is symmetrical, you have increased the slope. And this is something we can talk about in the question and answer. The distal biplane cut that's shown there, I would largely use for any osteotomy over 13 millimeters in the tibia, and that's to prevent unnecessary patellar baha. They're rare, those cases, particularly now we find for those big corrections, more and more we're doing a double osteotomy. That is an osteotomy in the femur and the tibia to maintain the joint line. The slope's critical. So this shows you the biplane cut. This is a slightly older x-ray, one of surgical picture, sorry, one of Neil Thomas and Adrian Wilson's. Actually won an award this, it was from a video, but that shows the standard HTO through a slightly larger oblique incision than I would do now, and shows nicely the normal osteotomy or the main osteotomy with the small biplane cut anteriorly. And you can see it on this sawbone demonstrated nicely here. What that does, you might ask what the advantage is. It's manyfold. It reduces the surface area of the gap healing massively. Roman Seil showed that nicely in a sawbone paper. It also increases the stability of the osteotomy because you've got bone on bone apposition in that anterior biplane cut. The other thing in a practical term is that anterior biplane cut is close. It might not be in full apposition, but it's within a couple of millimeters in most cases. And that will heal very quickly. There's CT evidence that will show some bony healing within 3 or 4 weeks. So it gives some inherent stability to the osteotomy. And that is why in a DFO, it's absolutely imperative that you do a biplanar osteotomy. The hinge is important. And again, we can go into this in more detail, but the hinge point is critical. It varies from patient to patient, but in very broad terms, if you aim for the tip of the fibular head, that will give you the rough ballpark area. That does vary in patients, however, and you want to be probably at least 10 mil from the joint line and about between 6 and 10 mil in from the lateral cortex. I think the main mistake learning osteotomy surgeons make is they leave the hinge too short, and actually when you start to open the bone, you're much more likely to get a fracture, and actually that's much more likely to be into the joint in a bad position. And Takeuchi classified these as 1, 2 and 3. I've actually labelled this incorrectly. I do apologise. A type 1 is this one, which is the most common one. And you could argue microscopically every osteotomy has a grade 1. And actually that's quite a safe hinge fracture to have. So that's why I would urge you to go close to the lateral cortex with your hinge position. A type 2 is down into the tib fib joint, and that is close to a disaster because that leaves you with a very unstable configuration. A type 3 is actually not as bad as a 2, but if it's into the joint surface, you should consider fixing it with a screw or screws above your osteotomy plate. So respect the hinge. Do this part of the operation slowly. We in Basingstoke use a precision saw blade, which is a beautiful device. It's safer for the neurovascular structures and it's much more accurate. It's only 1.2 millimeters in diameter, and you can really control it nicely. You can see it here with a radio translucent retractor. And here I would say about opening the hinge, do it slowly, do it carefully, use sequential osteotomes, use a graded device, but don't open it quickly. And these will all reduce your incidence of hinge fracture. In terms of fixation, rigid plate fixation is probably the way to go. It gives you the stability you want. These examples show a Tomafix in this nice 3D CT, which is a delayed union, I suspect. And this is a peak power plate, which is slightly less irritated to the tissues, but is basically as strong as a Tomafix and works very nicely. It has the slight advantage of being able to vary the angle of the screws, and also the advantage, and for the purposes of this X-ray, it shows the osteotomy nicely because the plate is largely invisible on X-ray. As I said earlier, smaller plates can be quite attractive and several companies have brought these out. This isn't a new plate. The Otis plate's been used for longer than a decade. It's actually quite a basic plate and it's based a little bit off the Poodoo plate. There are only 4 screws rather than 6 or 8. And I would use it personally for smaller patients, smaller corrections. What I mean by that is probably under 10 or 11. And I wouldn't use it in obese patients. Having said that, Sarah Gaglia, who's been using it for over a decade and is largely published, uses it for all comers with great results, but he does routinely use a gap filling bone wedge. That's synthetic bone filler in his case. I would use allograft, but we'll come back to that. As I said, I went with Dave Howard, our planning expert and assistant, to Grenoble, which is a lovely part of the world, to meet Professor Sarah Gaglia, as he's published widely on double osteotomies and computer navigated osteotomies. And the reason I went there wasn't for the computer navigation, but was to see his setup. And also, if I'm honest, to look him in the whites of his eyes and to know that the Otis plates worked. And certainly they do. The day I was there, we saw 2 procedures and 2 plate removals. He routinely removes the plates. And this is one of the plates at removal about 18 months after surgery. As I said, he uses synthetic bone to fill the gap. This is one of my own cases, and one of the things that prompted me to visit him and use smaller plates. This was a 48-year-old lady, very intelligent, professional jockey, a show jumper, for those of you who know what that is. Tiny, as jockeys tend to be, so 48 kilograms. And I went through the whole osteotomy thing with her. This was her medial compartment. It was grade 2 on X-ray, but grade 4 on an MRI and on arthroscopy. She had an intact ACL and a normal, essentially, lateral compartment. She wanted an osteotomy. She could ride a horse beautifully, still professionally, but she could hardly walk. She couldn't walk the course. She was really symptomatic. And we talked about osteotomy surgery, and I showed her an X-ray of a Tomafix plate, and she said, I won't quote exactly what she said because she used some bad language, but she said, I'm not having that in my leg because I'm going to be horse riding at 3 months and it's going to rub, and I'd like something smaller. And that was one of the things that prompted me to look at smaller plates. This is her planning. Just want to look at this briefly. So she was very subtly varus. You can see that on the middle picture. Her weight bearing axis is passing through at 28.6%, so the middle of the medial compartment, 6 or 7 degrees or so. And we planned her to 55%, accepting that we may be inaccurate by 5 to 10%. So I'd very rarely plan to 50 in case I'm leaving them in varus. And that equated to only a 5.7 mil osteotomy, something we'll do quite regularly in Basingstoke, because we are operating on earlier disease. An important point here is the saw blade thickness. It's something that largely passed me by as a registrar, but there's basic maths here. If you make an osteotomy cut, you've made that cut and it's 1.2 to 1.5 mil, however thick your saw blade is, but you've not corrected the bone. So if you then open the gap to only 5.7 mil, you've undercorrected by 1.2. Now that sounds really obvious, but do you know what? I think people do forget it, and I think they undercorrect. So particularly in these smaller corrections where that's a large percentage of your accuracy, please bear in mind the saw blade thickness. So when we actually did the operation, we did that, and here we go. If you look from the left, I've put my hinge point in there. My guide wires are pretty much exactly where I want the osteotomy, or just below them, aiming at the fibula head. And with my precision saw blade, I'm aiming for the hinge point. It's quite whippy, this Striker precision saw, and you can see it does deflect off the wires slightly, so you need to watch for that and take that into account. But I'm aiming for a hinge point within this safe zone here, which reduces the risk of a Takeuchi fracture. You can then see me sequentially opening it slowly, but constantly looking at the hinge to make sure it's intact. And there you can see our calculation, which isn't complicated. It was Dave's planning of 5.7 plus the saw blade. And what the assistant, Dave or Kinger in this case, would do the bone wedge from a femoral head. In our case, we have our own femoral heads at Basingstoke, which we harvest from total hip patients. He's made the wedge to fit the patient perfectly, which isn't for bone healing, because we know this will heal. It is purely to reduce pain and swelling post-operatively, which we are publishing on. I can't prove, but I suspect it does on average reduce that. More importantly, it increases the accuracy of your surgery, because if you have a bone block that is 6.9 millimeters at its wedge base, your osteotomy is going to be at 6.9 millimeters. And on another very practical level, particularly for the smaller osteotomies, it's less accurate to hold them accurately, say with a spreader, a laminar spreader. So popping that wedge in like a bottle in a cork gives you confidence, and actually it feels very stable even before you put the plate on. So it's a really good surgical tip. And here's the Otis C plus plate being fixed. This is a post-op x-rays, and you can see in this case we've achieved exactly what we planned, which is 55%. It's not Fujisawa, it's just at the lateral spine, just as we'd planned, and that's the plan there for you to reference off the x-ray. So we've talked about gap filling, and people talk about this a lot on the osteotomy courses, and to be quite honest with you, I do want to emphasize that Alex Staubli, and again this is the German group, Lobenhofer's group, published on over 500 HTOs using Tomofix with 100% union, and none of them had bone graft. So you do not need bone graft for healing. With some of the smaller plates and some of the bigger patients, you could argue you may lose correction, and bone graft may be useful for early stability, and certainly with the smaller plates that I would use that for peace of mind. I think allograft is probably the best, but a synthetic filler will equally give you that early stability and, more importantly, early accuracy that you want from your surgery. This is what we do at Basingstoke. This is some slides that Dave Howard produced a couple of years ago for the course. You can see the femoral head allograft having come out of the freezer, looking a bit tired. He cuts it like this and cuts the top off. He then measures the wedge and draws it like that. And what's beautiful about this is you can make a bespoke wedge for that patient with a trapezoidal gap. So the wedge base is, in this lady's case, 6.9 at the back, whatever it is at the front, 5 or something, and it'll pop in and fit perfectly. And this is just cleaning and washing that allograft to go into the gap, and obviously measuring it and confirming your accuracy against the measurements you've made. Here's a demonstration of that surgically. This is the peak power plate, which I did in the live surgery on the last course. And it's just, the reason I've shown that one is you can see the bone graft very nicely popped in there. And then once the plate's in on the post-op x-rays, you can actually see the bone graft beautifully sat in the gap there. We talked about double osteotomy earlier, and this is something that frightens a lot of surgeons, but we do a lot in Basingstoke, and in fact we get sent them as tertiaries, but I would definitely consider it as part of your armamentarium. When I was in Brisbane, I worked with Pete Myers. We did hundreds of osteotomies. He'd done thousands. Looking back, we often created secondary deformities and oblique joint lines by doing massive, particularly HTOs, and producing MPTAs of 97, 98 and oblique joint lines. Now, the patients did well clinically, but the x-rays looked funny. And if those patients did end up with total knees, you know, a decade or 15 years later. They were tricky in terms of the soft tissue. So I think if you can restore a flat joint line, then you should do that. And I think if you look at this case here, it's a classic example. So about 13 degrees of varus, worse on the right. And if you look at the plan, the overall correction is about 12.5, which for many of you would be a normal or average osteotomy. For us, it would be quite big. But if you do that just in the tibia, we were getting an MPTA of 98, 99, and it looked ridiculous. And you're creating a tibia valga. And that is because the patients don't have much deformity. Their deformity is in the joint line, the medial joint loss and the medial arthritis. So what we've planned here is actually a 6.5 mil closing wedge lateral DFO and a 7 mil opening wedge medial HTO. And you can see that looks beautiful, corrected to just past 50. And it gives you two smaller, manageable osteotomies with less chance of a hinge fracture. And actually, we do this increasingly now. I've done a couple of cases using the Otis system. On the femoral side, it's a more rudimentary plate, but you can use it for medial or lateral. It's cheap because it actually uses standard AO screws for many of the screw holes. It's just getting it a question to fit. And then obviously the Otis C plate on the tibia. So this is actually a typical case for a double osteotomy. It's someone with really quite severe varus. He was 59 a couple of years ago at the time of surgery. He's Nepalese. We have a lot of Nepalese patients in Basingstoke because of the proximity of Aldershot. And he has 15 degrees of varus overall. And we were aiming really for 50. You don't want to put these patients in valgus because they don't like it. But equally, you don't want to undercorrect. So there are his numbers. And this would have been a 15, 16 degree osteotomy, but it equated to an 8 mil on the tibia and a 7 or 8 mil on the femur, maybe smaller than that. I couldn't see it for Alan's face, sorry. The DFO here, you can see we always start with the DFO, partly because it's at the top end, but partly it's the slightly trickier operation in reality. And if anything did go wrong with the hinge or whatever, you could potentially bail out and not do the HTO. But in my experience, having done lots of these now, we can do the whole surgery in about an hour and a half, an hour and 45. So I'd start with the DFO. You can see we're doing a closing wedge, lateral DFO, cutting cage with the wires. And once I've made my osteotomy beautifully closed with no opening of the hinge fracture, but I think these patients all get a hole at the hinge. In fact, I would encourage osteoclasis and actually what I call tickling of the hinge to allow them to close safely without a proper hinge fracture. If you get a proper hinge fracture in a closing wedge femur, you need to then plate the hinge, and that's a pain. We've only had to do that a couple of times in Basingstoke, nearly once on a live surgery, but we got away with it. So there's the femoral osteotomy completed, and with the screws in the distal part of the plate. What I'd like you to look at there is look at the osteotomy before compression. So you can see there's a mil or so gap. But when we put the compression screw in and it was so tight, you can see we've actually bent the screw slightly. Look at that beautiful compression of the osteotomy. So bear in mind, this is a biplanar osteotomy with an anterior chamfer cut. This is a very, very stable osteotomy with a rigid fixation. And you can actually, in an isolated DFO, you can get them going very quickly, and they actually hurt and swell a lot less than the opening wedge HTOs. So in this bloke's case, we then went on to do the tibia. You can see I've highlighted the safe zone of the hinge point. This is after the cut and with the first osteotome in, and then again slowly opening to the 6 or 7 mil or whatever it was. This is fixing the Otis C plate, and this is the post-op film. We've slightly undercooked him, to be honest. He's probably at 48 rather than 50%, but a brilliant surgical result despite his quite significant medial OA. And you can see his long leg there. He's waiting for the second side, which is actually a single level osteotomy for him. Just briefly, because you may have seen Philippe Colombay's beautiful webinars on ACLs, I actually use the Philippe Colombay pull-up device routinely pretty much for my ACLs now, certainly on the femur, and you can use the pull-up XL on the tibia. The reason I wanted to mention ACL surgery is that personally and at Basingstoke in general, we've done a large number of combined ACL with osteotomy surgery. I've done a few PCLs. I've actually done one ACL PCL HTO for a salvage procedure. But it's really important, again, to go back to the first slide to talk about alignment with your ligaments, and actually combining an ACL with an HTO in a relatively young or middle-aged patient with instability and or pain is a very powerful procedure, and I think these are the best patients, but it's a double complex procedure, so there's some complexity around it. It says here, this is one of Adrian Wilson's old slides actually, but it says for a combined ACL osteotomy we should have early uni OA. I don't think that's true. A lot of them won't have OA, they may just have significant varus and a failed ACL, but most of them will have early or pre-OA. Some of them will have established medial OA. They must have some instability to consider doing the ACL. And I've said here, it's often a small coronal correction, normally from slight varus to slight valgus. Very, very occasionally, I've had valgus patients who have wanted to correct to neutral or varus with an ACL. But don't forget the slope. The slope is critical. As we all know, if you have an increased slope, that predisposes to ACL rupture. And certainly if you've got a failed ACL, look at everything. Look at the coronal alignment, look at the sagittal alignment before you start looking at tunnel positions, and look at the lateral ligament complex and consider all of these things. Because I would say a common operation for me is a failed ACL with early or moderate varus, and we're doing a combined HTO, slope reducing or slope maintaining with an ACL reconstruction, often a revision ACL. And in broad terms, the technique for that is to obviously plan carefully, pick your patient, but it's doing an arthroscopy first, sorting out your femoral socket first, then you do your HTO, then you sort out your tibial socket or tunnel, then you fix the graft. And I've said there, beware of the hardware. So sometimes smaller plates with fewer screws, plates specifically designed for this surgery can be helpful in order to get your tibial tunnel, because that's the main problem, tibial tunnel and tibial fixation potentially clashing with hardware. I know what Andy Williams does and what Pete Myers does in Australia is the slightly old-fashioned operation of a lateral closing wedge HTO, but it has minimal hardware, often just staples or a little plate, and that lends itself nicely to combining with an ACL. As I said, I use the pull-up for my ACLs and PCLs. It's a nice variable loop device that gives you that confident flip on the cortex, but then you can cinch it down. And the pull-up XL is a slightly larger button that you can use for a blowout or as planned for tibial fixation in a through and through tunnel. I also routinely use a lot of peroneus longus allograft from Hospital Innovations. I routinely reinforce it with a fibre tape, and I use that for revision ACLs, for PCLs, and for multi-ligament reconstructions on a fairly routine basis. Just lastly, really, because I could talk forever about osteotomy, it's my passion. We do some complex cases at Basingstoke. This isn't complex apart from the fact it was a double case. So this was a tertiary referral sent to me by a good knee surgeon up London way, a friend of mine, who said, I've got a 60-year-old guy, he's physiologically very fit, he plays tennis, he's charging around, but he's got really bad medial OA, really bad varus, and he definitely doesn't want a uni or a total knee. So he's come very self-selecting into that group, and you do see this group of patients. They're not always the best, although he turned out to be. And he asked if he could do bilateral at the same time because he wanted one period of rehab, and I get that. When I was in Brisbane, I asked Pete Myers this question, and he said he'd done it once and he'd never do it again because it was a disaster. But he was doing lateral closing wedge with staple fixation. So I would suggest in the right patient who understands the rehab and the difficulties of the first 4 to 6 weeks, doing this on very select patients is brilliant. And actually, Matt Dawson, our colleague up in Carlisle, has done and presented on over 20 now with brilliant results. And that's been my experience on the few I've done. So you can see how varus he was. Almost double osteotomy territory, but you can see he's got significant metaphyseal varus as well as his medial OA, and it was quite big corrections. I can't remember exactly, but 12 and 11 or something. And we did allograft bone wedges with him, and he's had the peak power plates done. This is him at 6 weeks post-op. You can see the relatively small transverse almost incisions that we make, and I accept that he's self-selecting into a patient who'll do brilliantly, but it does show what's possible with osteotomy surgery, and this bloke has no pain and is able to run around. So they really are good operations. And I would argue if this was someone in their 40s even, but even 50s or 60s, if or when it progresses, because you've corrected them to only a neutral position, you can still do a medial uni, and that's another excellent operation. But keeping them more into the green and amber zone rather than the red zone we talked about earlier And this is my final case, which is, again, quite rare, but we've seen a number now at Basingstoke, and I've got 2 on my waiting list at the moment. This is a 17-year-old lad, again, a tertiary referral, who had some sort of vague injury playing football at 13. He now plays semi-pro football for a lower league team, and amazingly was playing football as a centre-half with that knee. And he's got a 20-degree reverse slope, and this is because he had anterior growth arrest of his tibia, and we see this actually quite a bit. So always look at the lateral x-ray and get a CT if you're not sure. So what he needed was a anterior opening wedge osteotomy, and we've done quite a number of these at Basingstoke with a bone graft, and that's the reason I show it, is really the power of a bone wedge to help you with this sort of difficult surgery. So this is him in the operating theatre at EUA. He looks like a grade 3 PCL. On his MRIs, PCL is actually okay. It's probably stretched a touch, but it looked fine. And amazingly, his menisci looked fine, although the anterior horns of both menisci were under load. But he's got no damage. And I think if we can correct the slope at this age, rather than as a salvage, you're essentially giving them a normal knee. And you can see on the right-hand side, Kinger holding his leg up, and he's got that 20 degrees of recurvatum that you might expect. Massive quads, which were basically coping and stopping him collapse all the time. So this is him in theatre. We do it with the lateral x-ray. The more astute amongst you will notice this huge cut out of the front. So what you do is a massive long tibial tubercle osteotomy and reflect that superiorly. You can see it wrapped in a chlorhexote swab here. And then you find the hinge point, which is essentially the footprint of the PCL. Make a cutting cage with your wires. These are these bendable, breakable wires that are great for this. What you don't appreciate from these x-rays is the width of the tibia. So this guy is about 6'4", which is, I suspect, why he's had such a growth arrest. He's shot up from 13 to 17, a really big unit. And then when you've taken the tib off, your tibia is about 70, 80 mil medial to lateral. So I had to actually use 2 sets of osteotomes and 2 laminar spread attack devices to slowly open, and I mean slowly. So I opened this over about a 20-minute period so as not to break the hinge. But the key, as in the other operations, is the hinge point. So if it's within the PCL footprint, then there's some soft tissue stability at the back to prevent the hinge opening. If your hinge goes in this operation, I think you're probably in big trouble. What you can see there is the reverse slope at the start. And as I start to open it, it's just below 90 there. And at the end of the operation, we've restored him to a few degrees of slope. And you can see the wedge there. It's massive. I think it was 22 millimeters wedge base. And actually, once we popped that in, the knee was really stable. And what was amazing was you could pick the foot up and he had no recurvatum. So it essentially corrected him. And then what you do is what Ronald van Heerwaarden introduced to us at Basingstoke as a biological plate. So you fix the tibial tubercle osteotomy back in place. In this case, I've made it too short, so I've only been able to get 2 screws proximal and 2 screws distal. So I wasn't confident that that would be all right on its own, and I've used a Tomafix plate as well. But you can see his post-op film, and he's actually healed up now. He's actually 6 months now. I saw him the other day, and he's starting to run. Amazing results. So this was him at 6 weeks, and you can see already the recurvatum's completely corrected. That's him pushing back as hard as he can. You can see the wounds healed at the front. I was obviously worried about that with all the hardware and stuff. And this is him straight leg raising. So a really good result. So that really is just to showcase what is possible. And I think particularly with the PSI software we're developing, doing these more complex cases accurately, and certainly with the use of bone wedges.